my talk will focus on multimodality and the use of new modality and new information for increase the quality of treatment in modern radiotherapy. Next slide. I'm Pascal Fenoglieto. I'm the head of research and development in ICM, which is a cancer research center in Montpellier in the south of France. And we are focusing our treatments on oncology and on cancer treatments. So in our institution, we have different imaging departments. One department, radiotherapy department, where we have 7 LINAC, 6 from Varian and 1 from Vure, MR LINAC. We have 2 CT dedicated for virtual simulation for our patient. We have a nuclear medicine department and an imaging department where you can find, and you can see in the slides, a lot of different modality to acquire image to prepare the treatment for the patient. As you know, radiation has been discovered by image. This is totally unknown before, and it's using image that we know that radiation exists. And so imaging is totally, I would say, linked to radiation oncology since the discovery of radiation. In the last century, I would say, we have different type of modality we can use to define the target to prepare the treatment plan for the patient. You all know this modality, which are MRI, PET-CT, and CT scan. But since the last decade, there's a lot of different imaging used now during the treatment for the patient. As an example, we continue to use imaging to define the target and to prepare the plan of the patient, but we actually use the image in a daily basis to reposition the patient just before the treatment using KV image or 3D imaging like a CT scan, where we compare the preparation of the treatment to what happened in a daily routine. Far from that, actually in different centers, we use imaging more than the days before, because we use this image to check the delivery of the treatment. What I said is during delivery, during BIMON, we acquire on a trigger way different imaging, as you can see on the slide, different KV imaging to check if the target is really in the position we decide during the preparation of the treatment. And you see in this liver case here, at brief hold and inspiration and expiration of the breathing cycle, we realize KV imaging to check if the liver, as you see in the image, is in the position we defined during the preparation of the treatment, which is represented by the green contour here. The final evolution of using imaging during treatment arrived in 2017, where we are able to acquire imaging and a constant imaging during the treatment using new modalities like MR LINAC, where we can deliver beam and we can make radiotherapy during imaging of a patient. And you can have on the next slide some different example of what we are actually doing. So normally it must move. I'm sorry for that, but normally you have a motion of the imaging using MRI of this chest patient or this liver patient during the treatment. And you can see a green area here representing what we defined before the treatment. And the yellow area is what the system make as an auto contour during the treatment. And so we are delivering the beam only when the yellow contour is included inside the red contour. So we are checking continuously during the treatment, actually using imaging, the quality of the beam delivery. So what the specific needs in a radiotherapy department? We have to use a lot of information coming from imaging department. Why we need that? Because Imaging is a key point actually for a good quality of treatment in radiotherapy. As you see here, this is an example of what happened on our department since the last 2 decades. And you see there's a perpetual evolution of technology. And this technology leads us in a time of 20 years of a department, as you see in this slides, which is the department we have in 2000, to the new department in 2021, where you can see a huge improvement of type of linear accelerator we use. And all these huge improvements are coupled, I would say, to imaging with MR-Linac, with the possibility to make KV image during treatment of a kind of 3D acquisition CBCT, like a CT scan. So, as you see in this slide, radiotherapy treatment is globally included in an imaging process because we have imaging before the treatment, where we diagnose and staging the patient using all the type of new modality of imaging, and after, to follow the results of the treatment, to monitor the patient, we use imaging too. So the radiotherapy department and the radiotherapy treatment is globally included inside all this imaging process. What do we need? What do we need actually to have a high quality on treatment? We need spatial information. And the way to acquire a good spatial information is to have a high contrast in the image, which can be given in different pathology like this liver by MRI. You see in this slide that it's more easier to define the mets of the MRI than on the CT. But the same thing for prostate treatment. As you see in this slide, if you may take 2 radiation oncologists physician and you ask them to make a control of the prostate, only 62% of the control is the same between the 2 physicians. If you ask the same physician to make 2 times the control, you have only 60% by the same physician, an overlap of the control. But if you use MRI to define this control, you increase a lot the accuracy of the contouring, where you just have a gap of 2 millimeters between the different controls. So up to this spatial information, we need actually time information. We are treating some patients with a target who have some motion due to breathing of the patient, and so we have to manage this motion. We can manage it using a spirometer, where we put the patient in breath hold, so the patient stop breathing, and we are treating the patient in a and the target in a stopping position. Or we can use 4D acquisition. That it means we let the patient breathing alone and we reconstruct retrospectively after the imaging to define a kind of different frozen images of the patient. But actually, due to increase in technology, we have a possibility on certain machines to do that with an MRI. So to realize trigger image, so to acquire the image only in certain part of the breathing cycle of a patient, or to realize a retrospective 4D image with MRI, which is exactly the same as for the CT, but it means the patient is breathing alone, and after we reconstruct 6 to 10 different MRI at a certain position of the breathing motion. Functional information arrived since almost 20 years now and give us a next level of information for the treatment of the patient. This level of information is functional information, because radiotherapy up to this time was just deliver on spatial information, but not functional information. And now, using PET-CT or spectroscopic MRI, we can have functional information. But this functional information is difficult to handle, because depending on the level of the threshold of information you want to have, you can have different results. As you see here on the red area on the prostate, you see on the slide, depending on where you put the level and which threshold you choose of K-trans ADC, you can have different red region. And this is this red region which interests us for the treatment. If we want to use all this information to define a target to treat the patient, we have to be sure that this information is stable during the time. And if you look at this presentation using FMISO for showing the hypoxia of the patient, so to define a kind of marker for the target, you see 3 different PET-CT acquired at 3 different times, and the information is not stable. You cannot have control which are the same from one day to another, which is very difficult for us to use as a target because we don't have exactly the same information during the time. But some centers and some departments start to use this kind of functional treatment to improve the quality of a treatment, which is interesting here in the slides. We do not use functional information to define a target, but to define an organ at risk, where using a spectral CT, this department can show what is the functional part of the lung and to adapt the ballistic of the treatment to avoid the lung which is functional and to go with a beam through the deaf part of the lung. This functional information can be coupled too with time information, and it's what we actually use in our department here, where we realize a 4D PET CT to improve the quality of the definition of a target and to define this kind of tumor for MET in the liver with the liver moving with the breathing of the patient. Another thing interesting too is to manage the problem of metal artifact, because we have patients which are more and more old, and on the elderly patients, and we sometimes have some prostheses for the hips or sometimes some caps for the tooth, and this metal system creates some artifact, and these artifacts are very complicated to manage in radiotherapy. Why? Because you don't have information on the imaging, so you can't define the target. And so using this metal artifact reduction system, actually, you can improve the quality of the image as you see on the slides, and you can define the target of the organ at risk. But most interesting for radiotherapy than in radiology, we need to have the real accuracy of the on-field units defined by the system on the algorithm inside the prosthesis. Why? Because as we will deliver beam through the patient and through this metal artifact, if the on-field units reconstructed by the system on the image is not good, you will have a high impact on the dose calculation, on the dose delivery, and you can be totally wrong on your estimation in comparison to what you really deliver to the patient. So to use all this new modality of this new information, the provider of imaging are giving us new solution like dedicated MRI for radiotherapy, or evolution of CT like this new spectral CT here, with a big bore for patients in radiotherapy, or with a length of the acquisition of the detector increase in comparison to what we use actually on our department. So just a slide to explain you that what we are developing actually in radiotherapy is focusing a lot on MRI, and we are starting to change the use of a CT scan to an MRI to make what we call MR alone planning. So it means we make the virtual simulation on an MRI, and we go to dose calculation on this MRI too, going through a conversion of a MR image on a synthetic CT, on a pseudo-synthetic CT image, miming the CT because we need the CT for dose calculation. So as you see, we have a lot of information to manage to help us to define the target or to define the organ at risk, and how to use all this different information. We need to use a station. We need to use what we call a multimodality station who merge all this information on the same place on the same time. Because we want to catch all the information and to collect all this information to help us to increase the accuracy of definition of our target. So we have to put in the same time some MRI, some PET-CT, some 4D PET-CT, some 4D CT, some spectral MRI in the same time to earn time for the physician to define our target and to have all this information to really define with a high quality the area we want to treat. So you have an example here for treatment of a liver. So you see in this modality, in this multimodality workstation, we can display in the same time a 4D PET-CT, an MRI, a 4D CT with a phase of 0% of the breathing cycle, and an average of the image reconstruct of a 4D CT. And so in the same time, the physician can use all this information to control the target. And to do that, what we need to have a high quality system for registration, because all these images are coming from different systems. They are not acquired in the same time. So to have a good resolution of the definition of a target, we need to register all this image from one to the other. And so it could help us to define very small targets like the nodes in this patient, the pelvic nodes, where it could be very difficult to see them in the CT, and it's more easier using a PET acquisition to so where we have positive nodes in this patient. The same thing here, where we treat the lung patient, and it's interesting to have a pre-chemotherapy information of the target to define this area of treatment, because after chemotherapy the target shrink and it's more difficult to define the target. So if we have a pre-chemo CT, a diagnosis pre-chemo CT, we can make a registration and define this area as the target. And something interesting here, where we clearly see in the left of the image the motion of the metastasis of the liver on the 4D PET-CT, which is really more complicated to define in the right area, which is only a 4D CT. So this necessity of registration is very important, because you need a high quality of software to do that, because patients are not in the same position during the acquisition on different modality, as you can see in this head and neck case. And so we have to use deformable registration to really put the patient in the same position. And so sometimes we have some pitfalls and some problem, because we obtain imaging, as an example, for this prostate acquisition with this endorectal antenna, where it moves the position of the prostate, and after it's very difficult for us to make a good registration to define the target in radiotherapy. If we can, and imaging company are giving to us actually this kind of system, if we can go to hybrid machine, we will remove the problematic of registration, and we can increase the quality of target definition. So the advantage of this multimodality imaging system or software is to have a more precise control defined by the radiation oncologist, by the imager too, who can, as an example, nuclear medicine physician can make the control itself on this multimodality workstation, and this control after is belonging to the RT-CT for the definition of a target for the treatment. And as I said before, things are moving, because up to now we need and it's compulsory to have a CT scan for dose calculation, but as I explained just before, we are actually changing a little bit the rules and going to MR only system. So as I said, this multimodality workstation is really the tool of the physician because he has in one place, in one time, all this information coming from all the different imaging systems to define what you want to treat or what you want to spare with high accuracy. Okay, but to manage all this information, we need to have a system, a numeric system, and not to transfer information by CD-ROM or by USB key or thing like that. Because if we do that, it's a huge work just to load or to bring all the data in this virtual simulation console. Yes. The thing is, actually, for a patient coming in radiotherapy in a big hospital like us, where we have different imaging departments, we have a lot of information and a lot of imaging take in the different departments. And just transferring all this information can take a lot of time. And sometimes you miss or you lose information because you don't know actually where the image, on which server the image, on which station the image is stored. So even with a PACS, it's actually complicated to load or to have all this information very quickly and very easily. And we worked with GE 10 years ago on this kind of problem, and we were one of the first centers in France to use the new ADW server from General Electric. As you see in this slide, which is perhaps a little bit complicated to understand, we don't have a kind of spider links for all this information coming from different departments. But using the server, we only have one folder for imaging, all the imaging of a patient and this institution. So it's not different database, it's only one database with one patient, and all the imaging from nuclear medicine, from MRI, from CT for radiotherapy are in the same folder. And using this folder in ADW, this database, every department had the same software to work on this image. So it means if you make a radiotherapy CT and the afternoon the patient go to a PET CT as an example, the nuclear medicine physician can make the registration between the RT-CT and the PET CT, contour using his own system the target, the BTV as an example, and save it, and automatically, instantaneously, you have this contour by the physician who can be used by the radiation oncologist to define the treatment. And it is really, really very interesting because you can use all this information and all the expertise of all the experts, the different radiologist experts, to really define with a high quality the target you want to treat. So it's almost all. Thank you for listening, and I'm waiting your question.